Welcome to another NITMED tutorials. We're talking about an overview of antenatal care. It's a very brief and short overview. We've already done the antenatal care lecture, so this is just going to set as a reminder, point out some few facts. So antenatal care has actually been one of the most important things in the era of the obstetrics and gynecology. The presence of antenatal care has significantly led to a reduction in infant and maternal mortality, especially associated with pregnancy. Because Nigeria has one of the highest rates of infant mortality across the globe. And we hope that with an increase in antenatal care across Nigeria, there will be a decrease in infant and maternal mortality. So antenatal care is a perfect example of preventive medicine. We anticipate, we prevent, we don't wait for the problem to start. So the components of maternal care usually is preconception care, antenatal care, intrapartum care, postnatal care. Preconception is before the couples decide to go ahead and conceive a child. It usually involves things like genetic testing, review of past medical history, so on and so forth. And the antenatal care, which is what we're talking about, the intrapartum care, and postnatal care, or postpartum care. Preconception care is to assess the risk of pregnancy to the mother, assess the risk of pregnancy to the fetus, is to counsel couples on the risk and possible interventions, and then apply interventions to reduce both risk to mother and to the fetus. So, certain women have certain genetic conditions that might predispose them to risk. But not just that, they might have certain comorbidities. For example, now women that are usually elderly, greater than 35, women that are hypertensive, might have cardiac diseases, might have renal diseases, have serious chronic medical conditions. There's a risk of pregnancy to them. Usually they are termed high risk pregnancies, and this woman will require very thorough antenatal follow-up. And secondly is to assess risk of pregnancy to the fetus. Because if the woman has certain complications, even the child themselves are prone to complications. For example, a woman that has systemic lupus erythematosus usually develop antiphospholipid syndrome. One of the classic presentation is recurrent miscarriages. But in a scenario in which they conceive, because of this antiphospholipid syndrome, the child is prone to having some form of heart block. Secondly, patients with SLE are more predisposed to developing eclampsia and having child with inter-uterine growth retardation. So that's why preconception care is very important. We counsel couples at the risk of possible interventions such as cesarean section, termination of pregnancy, interruption of labor, so on and so forth. And then you apply interventions to reduce both the risk to the mother and to the fetus. So the aim of antenatal care is to ensure that both the mother and child are well. Pregnancy is a physiological state, it's not a disease, but there's a lot of stress placed on the woman because of the amount of changes she has to undergo in order to be able to bear and nurture a child in her womb. And also the child, given this very immature state, the child is under risk of a lot of things. So the child also has to be taken care of and monitored. So the aim of the antenatal care is to prevent possible complications. So they screen and prevent maternal fetal problems. They manage and treat problems, and then they prepare the couple for childbearing. Antenatal visits now. We have the first visit usually occurs before 13 weeks. And we have monthly visits in the first trimester up to 28 weeks. Then we have 2 weeks visits from 28 weeks, and then we have weekly visits from 36 weeks. Okay, but in high risk pregnancies, like we said before, pregnancies of advanced maternal age, pregnancies in which they had previous history of preeclampsia, eclampsia, or in which they have a bad obstetric history, that is, woman has had 3 or more recurrent miscarriages, has given birth to a stillbirth child, or we have a condition in which woman has a lot of medical conditions, renal failure, heart disease, so on and so forth. The frequency is usually increased in this case. You want to identify risk factors, you want to take a detailed history, do a physical examination, other investigations, full blood counts, you want to know her PCV and hemoglobin level and platelet count, you want to do urinalysis to check for glucose or protein in urine, you want to do glucose level, you also want to do a booking visit, you want to identify risk factors, you want to take a detailed history, do a physical and run some basic investigations. So some certain things you want to know. There are some pregnancies that are prone to being high risk pregnancies. One of them is the age. Maternal age less than 18 and age less than 35. Maternal age less than 13. less than 18, sorry, these people are prone to having some form of obstructed labor, which can then lead to complications like vesicovaginal fistula, these kind of things. Now, age greater than 35. First of all, the advanced maternal age is usually accompanied with chronic medical conditions. Could be some form of heart failure, hypertension, possibly diabetes, chronic renal failure. Height. When the height is less than 152 cm, you take into account that there's increased risk of cephalopelvic disproportion. Okay, because the passage tends to be smaller than the passenger, so there's problem with the process of labor. Weight greater than 45 kg, greater than 100. Greater than 100 is usually associated with some form of diabetes mellitus, gestational diabetes, and gestational hypertension, smoking, alcohol abuse, substance abuse. All these could be risk factors for preeclampsia and also could lead to some form of vasoconstriction affecting the placenta vessels, so the child might not be able to. So these are certain risk factors we want to ascertain, and then the socioeconomic status, like we all know. Okay, and also we know that advancing maternal age is also a contributing factor for Down syndrome. You want to take a last menstrual period. Usually they are assessed by up to 2 weeks. You want to take a history of oral contraceptive, presence of intrauterine copper device in situ, vaginal bleeding, past obstetric history. Parity greater than 5 is what we call grand multiparity. Congenital abnormalities, perinatal death, IUGR, macrosomia, preterm labor, previous cyclage, antibodies in pregnancy, hypertension, cesarean section, any third stage complications. These are things you should assess while taking your past obstetric history. Now, medical history, very, very important. So, sickle cell, hypertension, asthma, diabetes, epilepsy, in addition to renal diseases. Okay, chronic medical disease, common ones: sickle cell, hypertension, asthma, diabetes, epilepsy. You can take a history of peptic ulcer disease also. Now, don't take into account the history of chronic renal failure. Chronic renal failure, patient with chronic renal failure, hypertension, they have a fourfold more chances of developing gestational hypertension, preeclampsia, eclamptic syndrome. There's also the medications patient is on. Some drugs are teratogenic. For example, now ACE inhibitors, ARBs are teratogenic and should be avoided during pregnancy, and also some anti-thyroid drugs. Those are things you have to take into account. Family history of fetal abnormalities, medical condition, multiple pregnancy, hemoglobinopathies, very, very important. Even the high incidence of sickle cell anemia in Nigeria. Booking examination, check your blood pressure, maternal weight, maternal height. Maternal weight is also a risk factor to assess the possibility of the person developing gestational hypertension. So the higher the maternal weight at the booking, the person might be a potential diabetic. Uterus incompatible with dates. The uterus being too small, being too much. Uterus size being too much points to things like gestational trophoblastic disease, because the uterus is usually larger than normal in those cases. The uterus being too small might be that the woman doesn't actually know her date. Suspect some form of intrauterine growth retardation, so for example, for pelvic masses. Also, uterus being too large could also point to presence of fibroid also together with the pregnancy. Some basic investigations: PCV, blood group and rhesus, HB genotype, syphilis, HIV, booking SS, booking ultrasound, and also rollout torch infections. Very, very important.